So today I've been asked to actually talk about three different subjects, a little review of COVID-19, vaccines, both COVID vaccine and influenza vaccine, and then I'll spend a little bit of time talking about misinformation and how it can really cloud our interpretation of illnesses. So I'm going to give you a few slides on COVID-19. I'm going to make some comments on Guillain-Barré syndrome because some of you may not know some of the features of it. Then we're going to talk about vaccines and Guillain-Barré and can they be causative. We're going to talk about COVID-19 infection and Guillain-Barré, COVID-19 vaccines and Guillain-Barré, and then the flu vaccine, who should be vaccinated and who should not, and then we're going to spend some time talking about misinformation. I have a pointer here, but I have two screens. So I don't know which one I should favor using the pointer or whether I should just use my vocabulary to try to walk you through some of these slides. So many of you will not need a review of COVID-19. We know that it began in Wuhan, China in December of 2019. We still don't know exactly what happened in that very large China city. The alternative name for COVID-19 is SARS-CoV-2 because there was a SARS-CoV-1 quite a few years before that. We know that it's transmitted by breathing infected droplets or contact with infected droplets on a surface, and then you touch it to your nose or your mouth or to your eyes. The incubation period is about 5 days. It can be shorter, it can be longer, and one must keep in mind that even though there is a belief that COVID-19 is on the wane, and it is, still in the United States, up to 400 people per day, not per week, per day, die from COVID-19. So it's still with us. So what are the symptoms of COVID-19? As I mentioned, the incubation period averages 5, it can be 2, it can be 14 days after exposure to the virus. The major symptoms are on the left and some on the right: fever, chills, dry cough, shortness of breath, difficulty breathing, fatigue, muscle or body aches, headache. New loss of taste and smell has been talked about for a long period of time. Sore throat, congestion, nausea, and diarrhea. On the right are more severe complications of the illness: severe bilateral consolidated pneumonia, ARDS, which is acute respiratory distress syndrome, which is usually due to the severe bilateral consolidated pneumonia. Then there can be multiple organ dysfunction involving the brain, heart, peripheral nerves, which I'll talk about in a minute. The case fatality rate is 2 to 3%. 30% of people have no symptoms at all. They're what we call asymptomatic. More than half of people with COVID-19 have a mild disease: congestion, a little bit of shortness of breath. 10% are severe, and then critical symptoms are up to 5%. And then the neurologic complications. So we're here talking about GBS, CIDP, and multifocal motor neuropathy. They're neurologic, they involve the peripheral nervous system. But there are central nervous system complications of COVID-19, and those include dizziness, headache, cerebral vascular disease or stroke, impaired consciousness, transverse myelitis, which is a disease of the spinal cord, where people have symptoms below the level of the insult. Then there's encephalopathy, which is a medical term for people who have brain involvement, epilepsy, ataxia, which is difficulty with coordination, more often of the legs. And then I think you've all heard of the term brain fog, and brain fog can be a symptom of COVID involvement, which actually would be a form of encephalopathy. So in the peripheral nervous system, we have difficulty with taste, impaired smell, neuralgia, which is nerve pain, and we heard about that in the prior presentation. Then there's Guillain-Barré syndrome, and I'm going to talk about that. And you can also have skeletal muscle damage from COVID-19. And then what are the risk factors for getting COVID-19? In other words, what kind of conditions can you have that make you more prone to get COVID-19? And those include cancer, chronic kidney disease, COPD, which is chronic obstructive pulmonary or lung disease, obesity, impaired immunocompromised state, serious heart condition, sickle cell anemia, type 2 diabetes. Keep in mind that about 38% of the population of the United States is either diabetic or chemical or borderline diabetic. And then vitamin D levels, which are low. So that completes my extremely brief review of COVID-19. So let's spend the next 4 or 5 slides talking about Guillain-Barré. Many of you have experienced it, some of you have not. So Guillain-Barré syndrome probably should be called Guillain-Barré-Stroll syndrome. This was first reported in 1916 in 2 French soldiers with paralysis and tendon areflexia. They were in the trenches during World War II. 1916 was the year of 2 major, huge battles, Battle of the Somme and Verdun. In both battles, almost 1 million men died. Now, of interest, about 70 years before 1916, a French neurologist named Jean-Baptiste Landry reported 4 cases that would later be called Guillain-Barré syndrome. And what is really unfair about this illness is that if life were fair, we might be calling this Landry's ascending neuralgia or neuritis rather than Guillain-Barré syndrome. The authors, Guillain-Barré and Stroll, never mentioned Landry in their reports in 1916. Albumin cytologic dissociation is just the elevation of protein without white blood cells in the spinal fluid. It's really unclear why they did a lumbar puncture, since the lumbar puncture had just been discovered about 20 years before that. Guillain, one of the French neurologists, said that in order to make the diagnosis, you had to have a protein greater than 300. We really don't know where he came from in making that assertion. And then Stroll was a physiatrist, a very young physiatrist from Alsace-Lorraine, which is a small community between France and Germany. And for unclear reasons, Dr. Stroll's name was dropped off of the condition Guillain-Barré-Stroll after about 1925. So several mysteries here regarding the illness. So the demography, it is the most common cause of acute or subacute flaccid weakness. Now, if I were giving this talk in the 1930s or 40s, it wouldn't have been Guillain-Barré, it would have been polio. Most patients with Guillain-Barré syndrome are previously healthy. The incidence is 1/2 to 2 per 100,000 people in any country. Men are more likely to get the disease than women. It can affect all age groups, and you heard that Lisa's son developed the illness at the age of 5.5. It occurs in all seasons of the year, and your lifetime risk of developing Guillain-Barré is slightly less than 1 per 1,000 people. So what infections are associated with Guillain-Barré? So we know that about 70% of people with Guillain-Barré are preceded a week or two before by an infection, often viral, often bacterial. The most common ones are the 7 that are at the top. Campylobacter jejuni, which is seen in about 40% of people with Guillain-Barré syndrome. Then cytomegalovirus, which often presents as a hepatitis. Then Epstein-Barr virus, Mycoplasma pneumonia, hepatitis E, and many of you may remember reading about the Zika virus, which was most prevalent in Africa about 10 to 15 years ago. And there's our friend SARS-CoV-2, which I'll tell you can produce Guillain-Barré syndrome, but the incidence is not greater than it is after other infections. So what are the neurologic symptoms of Guillain-Barré syndrome? They often begin with paresthesias, tingling, and pain, often in the feet, climbing up the legs, in the fingertips, climbing up the upper extremities. Patients early on have difficulty walking. They have bilateral weakness of the lower and upper extremities. They have difficulty with breathing. They can have blurry vision. They can have difficulty with swallowing, speaking and chewing, incoordination due to the weakness and the sensory loss that people get with this condition. And they can also develop what we call autonomic complications. And the autonomic nervous system is responsible for regulation of HR, or heart rate, blood pressure. They can have fluctuations of hypertension and hypotension. They can have difficulty with digestion and bladder control. And I think that really completes what I'm going to talk about with Guillain-Barré. So what about vaccines and Guillain-Barré? It's been talked about since 1976, and we'll get into that in a minute, and it continues to be a hot topic every fall when it's time to get vaccines. So before I get into vaccines, you need to know a little bit of the background information about the influenza infection. This is a natural infection from influenza unrelated to the vaccine. So each year, almost 500,000 people are hospitalized in the United States for the influenza infection. Almost 50,000 people in the United States die from the influenza infection. Influenza is the 6th leading cause of death of adults in the United States. And so the whole purpose of the flu vaccine that is given in September and October is to prevent the numbers that I'm showing you right now. So how about infections and Guillain-Barré? And I just told you that approximately 70% of people who contract Guillain-Barré several days before, several weeks before, will have a gastrointestinal or upper respiratory tract infection. And ironically, it tends to be mild. And sometimes the patient even forgets that they had it before the Guillain-Barré begins 10 to 20 days later. The most common cause is infection with the bacteria Campylobacter jejuni, which causes a gastroenteritis and is usually manifested as diarrhea, and we often just attribute it to the flu. People can also develop GBS after the flu or other infections. And on rare occasions, and we'll talk about that, people can develop GBS in the days or weeks after receiving a vaccination. Now, that doesn't mean the vaccination caused the problem, because not uncommonly, some of these people also had a GI, a respiratory infection, completely unrelated to the flu vaccination. So what began the controversy about vaccinations and Guillain-Barré? And you can go back to 1976, it all pretty much began then. So the swine flu was the major flu infection predicted for 1976. And there was a major outbreak of flu in Fort Dix, New Jersey in 1976. This raised a concern that this might be a horrible epidemic or pandemic for the United States, because the swine flu is an H1N1 form of flu, and it's the same organism or type of organism that caused the famous 1980 pandemic, which went by the name of avian flu or swine flu. Just to remind you, in 1918, the flu vaccine killed almost 1 million Americans and 50 to 80 million Americans worldwide. So the federal government decided to develop a special H1N1 vaccine to prevent the epidemic or pandemic that was predicted. The inoculations were started in September. They were stopped in the middle of December of the same year due to reports of a higher incidence of Guillain-Barré syndrome. Later investigations showed a clear relationship between the 1976 flu vaccine and the development of Guillain-Barré within 42 days, and the increase was thought to be about 9.5, although this number was later reduced to 4.9 to 5.9 by further research. Due to this, future vaccines have a warning about Guillain-Barré syndrome. Now here is a graph of how severe the Guillain-Barré was over 17 for population of people who received what was called the New Jersey influenza vaccination of 1976 and early 1977. The vertical line on the left are cases per million. The horizontal line are months of the year, October, November, and December, and January 1976 to 1977. The lower line, the stippled line, is the incidence of Guillain-Barré in people who weren't vaccinated. It's pretty low, baseline. The solid line was the risk of developing Guillain-Barré with vaccination. And as I told you before, the original estimate was 9.5 increase compared to a baseline. On the other hand, much research has been done for flu vaccinations after 1976, 1977. And in this slide, over on the left, there are, I believe, there are 11 publications. There are the authors from 1982 up to 2013. The light blue line is the incidence of Guillain-Barré without vaccinations. The orange dots to the left would be a reduction of Guillain-Barré after vaccination for that year. The orange dots on the right would be a slight increase. If you look at it, there are 5 orange dots to the left, 6 to the right. So really, this is a wash, suggesting that there's really no increased incidence of Guillain-Barré after receiving the flu vaccination in the years indicated in this slide. Here's another analysis of Guillain-Barré after influenza vaccination. In this slide, there are 10 reports on the left with their authors, and then the next column over is year, then study design, vaccine, and then the important result or outcome is on the right. You can see that there was a 9.5 increase in additional cases in what I've already told you about 1976, early 1977. But notice in that column that most of the authors found no increase in Guillain-Barré. One author found actually a decrease in Guillain-Barré after flu vaccinations. Then other authors found no increase, a very small increase, and one additional per million, confirming that there's really no solid data to be concerned about when it comes to the flu vaccination, when you consider that the vaccine is protecting you from being someone who dies from the influenza natural infection. And here's another slide. The left are potential causes of Guillain-Barré, Campylobacter, Epstein-Barr, influenza-like illness, then influenza vaccination, polio. And if you look at the cases, the percentage and controls, you'll see that you're much more likely to get Guillain-Barré after the influenza-like illness than you are from the influenza vaccine, which is below that. And this is the analysis of the risk of Guillain-Barré in influenza vaccinated and unvaccinated people in 2009 and 2010. And the importance of this is the fact that this was an H1N1 vaccine. So this is the type of vaccine that raises our awareness of a potential relationship between the vaccination and Guillain-Barré. So the stippled area is unvaccinated, and the solid area is below that, telling us that there's not only no relationship between the vaccine and Guillain-Barré, but some people might interpret this as saying that the vaccination protects you from getting Guillain-Barré. So what are some of the other research review articles? This is a study by Haber and his group at the CDC, and they looked at 69 references relevant to the relationship between vaccine and Guillain-Barré. And on the left, I'll just read to you, our review indicates that with rare exceptions, associations between vaccines and Guillain-Barré has been only temporal, meaning you get the vaccine and then you get Guillain-Barré later on. There is little evidence to support a causal association with most vaccines. The evidence for a causal association is strongest for the swine flu vaccine that I've already told you about in 1976, 1977. Studies of influenza vaccines used in subsequent years, however, have found small or no increased risk of Guillain-Barré syndrome. Roger Baxter and his group at Kaiser Permanente, Northern California, not only looked at relationships between the flu vaccine and Guillain-Barré, but other vaccines as well. And their conclusion is in this large retrospective study, and it was a very large study of millions of patients, we find no evidence of an increased risk of GBS following vaccinations of any kind. So this was not only flu vaccine, but measles and mumps and hepatitis and other ones that I'll tell you about in just a minute. So what about the very important topic of getting a flu vaccination after you've had confirmed Guillain-Barré or CIDP? Well, Quidward and her group in the Netherlands in 2019 published their result of a questionnaire or a telephone conversation with people who had Guillain-Barré, CIDP, and had received a flu vaccination after that. So her results were looking at 245 patients with prior Guillain-Barré, 76 with prior CIDP. In the 106 GBS patients who answered the questionnaire, there was no recurrence after flu vaccine, not a single one. Of the 24 patients with CIDP, 5 reported increased symptoms, all mild after the flu vaccine. Most of them were mild and short-lived and didn't require any change in management for that patient. Her conclusion and that of her authors was that the flu vaccinations are relatively safe for people with Guillain-Barré and CIDP. And I mentioned this slide because it's such a common issue and discussion at meetings like this, as well as phone calls to the foundation. What about other vaccines and GBS? There have been reports of GBS after other vaccinations. The Institute of Medicine of our country published a huge textbook 1 or 10 years ago looking at the relationship of vaccinations to many conditions, neurologic and non-neurologic. And it was their conclusion that there is inadequate evidence to draw conclusions between the vaccine for mumps, measles, rubella, varicella, hepatitis A and B, human papillovirus, diphtheria, tetanus, or pertussis, and Guillain-Barré syndrome. So what about COVID-19 and Guillain-Barré? So we're now going to talk about the natural infection with COVID-19. So this is a publication in the Frontiers of Neurology where they looked at 51 high-quality studies, mostly consisting of 83 patients, and their conclusion was you can get GBS after a COVID infection, but the incidence is not increased, and when you are seen for GBS, you should be tested for COVID, which I think is pretty standard nowadays. As soon as you walk in or are wheeled into the emergency room, they're going to test you for COVID-19. So Keedy and his group in the UK, early in 2021, did an epidemiologic and cohort study finding no association between COVID-19 and GBS. In other words, there isn't an increase in GBS after COVID. And what they did is they looked at their data in 2020 and they compared it to the epidemiology of GBS from 2016 through 2019. They found that the incidence of GBS from 2016 to 19 was 1.65 to 1.88, whereas in the UK in 2020, from March to May, this is only 3 months, there was actually a considerable drop in the incidence of GBS after COVID infection. So it was their conclusion that there's no epidemiologic clue for COVID-19 more commonly leading to GBS. But there was a subsequent study published also in 2021, and this was done in Athens, Greece, and it was a meta-analysis. In other words, they looked at 18 prior publications and 136,000 people with COVID-19. Among the patients who had COVID-19, the pooled prevalence was 15 per 100,000, whereas the average rate in their general population was 2. The incidence was not present in most countries because the data was extremely skewed by the high incidence of COVID-19 in Italy. And it was their conclusion that the data was influenced by the data from Italy, and that at least in most countries there was no increase in GBS after COVID-19. They also said the association of GBS to COVID was weaker than the association of the two most common preceding illnesses, which are Campylobacter jejuni and cytomegalovirus. So another study published in the Annals of Neurology looked at a large number of clinical and risk factors for Guillain-Barré. And their conclusion is that people who do get GBS after COVID-19 might be more frequently admitted to the ICU, but their mortality was not increased compared to control groups of patients admitted to the ICU. So what about COVID-19 vaccines themselves and the development of Guillain-Barré syndrome? So we know that in July of last year, the FDA published data suggesting that Guillain-Barré syndrome is more common after the Janssen vaccine, or what is called the Johnson & Johnson vaccine. And they issued a warning about a slightly increased incidence of GBS. They had detected 100 suspected cases, and keep in mind that suspected doesn't mean they have GBS. That means that they need to look at the data more firmly to make sure that all 100 had GBS. They calculated an excess of 1 per 1,280,000 people developing Guillain-Barré after the Janssen or Johnson & Johnson vaccine. They stated there was insufficient evidence to establish a causal relationship between the Janssen and Johnson vaccine, and there was no need to avoid the Janssen vaccine. So there have been actually 2 studies now that have shown no significant increase of GBS after COVID vaccination. Both of these have been published within the past months. They were both published in September. So the study at Rutgers here in New Jersey, published in Vaccine, they published their data in response to what I've already talked to you about, the FDA warning about the Janssen and Johnson vaccine. They did a passive surveillance data from VAERS website. VAERS is the Vaccine Associated Reporting System. They used the Brighton criteria, which is used to substantiate whether the patient had GBS or not. They wanted everyone to be aware that 10% of patients had a prior infection in addition to receiving the COVID vaccination, making interpretation of the data more difficult. Excuse me. The reporting rate of GBS after COVID vaccination was 4.97 per million, which is in the range expected in the general population not receiving a vaccination. So they felt that the risk of GBS after COVID vaccination was insignificant compared to the risk of GBS after other complications of SARS infection, which I've told you about already. Excuse me. And then the other study that just came out within the past months, Green Journal, Bears, and the group from Holland, they talked about the vaccination safety of the COVID vaccine in patients with GBS, CIDP, and multifocal motor neuropathy. So these are people like you in the audience. And they did a prospective study over a 7-month period of time last year. They had patients who had prior GBS, CIDP, or multifocal motor neuropathy complete a questionnaire regarding whether they got worse after receiving the COVID vaccine. So this is before 4 weeks and later in the time period after receiving the vaccination. What's interesting is not a single person with GBS had a recurrence after the vaccine, not a single one. 5% of patients with CIDP had recurrence of symptoms within 6 weeks, all mild. 3% of patients with CIDP required some modification of treatment regimen, IVIG, prednisone, plasma exchange. 4% of patients with multifocal motor neuropathy had recurrence, and it was their conclusion that the COVID-19 vaccine appears to be safe in these 3 disorders. So the conclusions appear to be that there's no increased risk of GBS from any of the mRNA-based vaccines, those are Pfizer and Moderna. No increased risk of GBS after the Janssen vaccine. In the one of the articles, they reiterated the results of a prior publication by Anjo Uvant that the chances of a neurologic event after receiving the vaccine, or after the natural infection, not the vaccine, is 617 times higher than any complications from the COVID vaccine. This is a pretty powerful message. We need to continue to monitor. So who should be vaccinated? We're going back to flu. Who should be vaccinated for flu? Well, everyone who's at least 6 months old, and then a long list of people with underlying medical problems, asthma, diabetes, chronic renal failure, pregnant women, yes, people 50 years or older, American Indians, Alaskan Natives, extremely obese people with a BMI greater than 40, and residents of nursing homes and assisted living facilities, as well as people who care for those who are high risk. The flu vaccination, what if you've had GBS? Well, the risk of a former GBS patient developing GBS again from a vaccination is not known, but we now have 2 publications to show that that is extremely low or non-existent. Our foundation, the GBS CIDP Foundation, the Global Medical Advisory Board guidelines is for anyone who's developed Guillain-Barré within 4 weeks or 6 weeks of receiving a vaccine, it probably would be a good idea to avoid that particular vaccination again. For those whose GBS did not follow soon after the vaccination, there is no reliable data to really give you precise recommendations for the vaccination. And I know this is a somewhat nebulous recommendation here. So what about COVID and misinformation? And This was a real education for me as I poured through the internet and saw the misinformation, some of it humorous, some of it downright sad. The Kaiser Family Foundation listed falsehoods about COVID-19 or COVID vaccine. The government is exaggerating the number of COVID-19 deaths. Another is pregnant women should never get the COVID-19 vaccine. No data to support this. Deaths due to COVID-19 vaccine are being intentionally hidden by the government. No. COVID-19 vaccines have been shown to cause infertility. No evidence for that. Ivermectin is a safe and effective treatment. Ivermectin is only used in animals for parasitic diseases. You can contract COVID-19 from a vaccine. No, you can't. COVID-19 vaccines contain a microchip that allows the federal government and other organizations to follow you all around, including this meeting. COVID vaccines can change your DNA and cause diseases that are due to DNA. And I think one of the most insulting ones that wasn't listed is that doctors are paid more if they give COVID vaccines in their office, up to $1,500 per injection. A second one, myths about COVID and COVID vaccine. This is from the Mayo Clinic, Global Citizen, this year. COVID-19 does not affect children, not true. COVID-19 primarily is transmitted in hot and humid climates. Well, that's true, but it's also cold and less humid climates. Antibiotics are effective in preventing and treating COVID infection. Well, COVID infection is a virus. Antibiotics are not useful in viral infections. They would be useful if you developed a super infection bacterial from COVID, and that is the case if you're in the ICU and you have a pneumonia. It may be bacterial. Pneumococcal vaccines protect against COVID infections? No. They protect you against getting pneumococcal pneumonia. Eating garlic protects against COVID infections. Regularly rinsing your nose with saline helps prevent COVID-19? No. Ultraviolet disinfectant lamps kill the COVID virus? No. Spraying alcohol or chlorine all over your body kills the COVID virus. And a hot bath kills COVID vaccine? Not true. So I'm finishing up here. How to address the COVID-19 misinformation. First of all, always consult with your primary care providers, whether it's your physician, your internist, your family doctor, your nurse practitioner, your physician assistant. They are in a far better position to clarify issues of misinformation. Know your sources of information. Where is it coming from? Is it coming from reputable sources? Beware of digital sources dependent upon social media informers. You know who they are. Most of them, I don't even know how to get on their websites. You may. So this would be television, certain channels, radio, websites, Twitter, and other social media. The other thing is ask yourself, does the information make sense? Do you really think that the vaccine changes your DNA? Do you really think it leaves a marker that you can be traced throughout the United States? I don't think so. And then remember the reason vaccines are developed. They're developed to prevent disease. They're not developed to make you sick. And so keeping that in mind the next time you get a flu vaccination. Remember that if you don't get a flu vaccination, you may be part of the 40,000 people in the United States who die from natural influenza.